Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast, we interview subject matter experts, authors, and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health, and how to get people back to their best. We hope you can take away some content and use it in your practice. All right, welcome to the PTR Physiotherapy Rehab Podcast, where we explore musculoskeletal physiotherapy and rehab topics. We are currently talking about manual therapy and how it's taught at university. This is a follow-up episode to a previous one we've done on the paper that was published by the three gentlemen joining us today. And today we're going to just explore how those manual therapy implications are felt or taught at university. So we've had the introductions on the previous episode, so we don't need to worry about that. But if I can go to Ken, Roger, how is it that we are feeding this back to university, or as a lecturer yourself and a teacher yourself, how has this impacted the way you teach manual therapy at university?
So who's going first?
Roger, sorry. Yeah.
As we said on the last episode, this is sort of grown from the way we changed doing things anyway at Nottingham. So it's sort of not something we've had to implement. It's something we sort of just grew with and developed anyway. Right. I mean, you know, the way it looks, if you walked into a class, it doesn't look much different to how manual therapy has always looked. There's still people holding bits of other people and moving them around and things like that. It's the reasoning and it's the drivers of what's making that skillful technique that's changed. That's all. So, you know, very practically, shop floor, we just go in. We have on the screen the big triangle with safety, comfort, efficiency, and that drives everything. And we say, okay, let's learn how to move somebody's neck. So safety. I know it's a good idea not to have your thumb right over the carotid artery, so let's not do that. And then comfortable. What about some really nice sort of large contact area with your hands around the back of the neck on that lovely soft tissue, and make sure your posture's nice, make sure the height's right, make sure your patient's head's nicely on a pillow or whatever. And let's do this really efficiently, because we don't want to spend much time doing this, because the aim of this is to get somebody to do their own movement. Let's teach this patient how they can move their head, because they haven't done it for some months now because they've been worried about movement. Sure. And they've got this belief about their body and pain and movement, and we can really help, you know, in a safe, comfortable, efficient way, really help to do that. And you know, essentially that's how it kind of looks. And sure. There's still high skill levels in that, you know, this isn't about de-skilling us. You know, the handling, the therapeutic touch, the care, if anything, is sort of upskilled, you know, sure. in that context. And so from my point of view, you know, that's basically my simple story. There's nothing much more grand to it than that. I mean, Vaz has been on this journey all the way along as well, so I don't know sure. If he wants to add anything else.
So I'm trying to think as you were talking, Roger, whether, you know, I would say that things are not the only thing that is different. The only thing that is different is that we just do not spend any time at all discussing specific levels. We can discuss the risks of mobilization, for example, or spinal manipulation. We can discuss why there is no evidence to support, for example, an upper cervical spine manipulation and, you know, the carotid artery and things like that. We discuss red flags. Certainly, this is part of the safety component into our model.
Sure.
But we do not spend any time discussing all this facet joint. And actually, we discussed that early on, because with the approach that we have is we start like from the neck, and then we go down the body as the weeks progress into the module.
Okay.
And we say, like, this idea that, the pain is there and then you're going to mobilize that just does not exist. So you just need to basically just mobilize the neck. And the evidence suggests that, even if you do a thoracic spine, you can still achieve cervical pain relief basically in the neck. So, even if you don't feel confident enough to do it, which again reduces your safety, then therefore you have to actually move to something safe, then you can still have the skills there to actually proceed and do spinal manipulation. So we don't take anything away from manual therapy. The only thing that we just trim out is all this illogical specificity.
Okay. So if I'm being sort of coming from the other side, where if I was, again, I'm kind of pro for all of this, and that's why I wanted to talk about it, because I think it's really useful. But if somebody was coming in who was very the other way, and they were saying, well, look, how are you teaching a student to differentiate from, if somebody came in with an L4, like a lower left back stiffness, and you assess that with range, you found that they were very stiff to side flexion, they were stiff, and essentially they were sore, but stiffness was also quite a big part of the picture. How would you teach them to use manual therapy to improve range and reduce stiffness if we're not using grades 1 to 4, or if we're not using a specific depth? Are you teaching them to go as far as you can cope, or as far as the patient can cope at each level, or around that area?
Do you want to
in
start,
that
Roger?
respect?
Sorry, I started talking and my mic was muted. For me, again, I'll let the others sort of charge on with this, but for me that comes under that comfort and efficiency thing. So rather than thinking of a predetermined amount of force you're going to put on, which is a strange thing anyway, you'd work with the patient and apply the amount of force, or whatever you want to call it, in a particular direction that meets their functional aims. Like say, so we've got stiffness into side flexion. Obviously that's given this, if severity and irritability allow, then we can move into that and it's comfortable, and you're doing it in the efficiency is a really powerful thing, because rather than talk about grades 2, 3 or 4 or whatever, we just want to get that movement reprogrammed as quickly as possible, and that will then dictate the amount of force and the amount of repetitions or whatever we do. So we kind of, I don't know, is it sort of flipping the model round a bit? It's I guess it is in some ways. You're working with the patient to get the movement restoration done as quickly as possible, and that will inform the amount of force. That's in my mind. Again, be interesting to see what Ken and Vaz have got to say on this.
The only thing that I will add, and then I will pass it on to Ken, is that I think, again, this is kind of follows the logic that manual therapy is the end here and not really the mean. So it's just basic assessment. I mean, you wouldn't jump in and do manual therapy anyway. You would assess the situation, you would assess the patient, you will try to test the waters basically to see what's happening. And that testing would give you the idea whether you can actually do manual therapy, or whether you need to push harder, or whether you need to push softer. Your patient will tell you, not your belief that you can understand where the resistance is coming from, or where the resistance starts and where the resistance ends, and like categorize that in your head in a way that makes sense only to you. It's very subjective. And okay, let's say that I have decided that it is like grade 3, and actually the patient does not allow me to go beyond grade 1. So I mean, what happens there? You still inform your approach based on what the patient tells you. So why do you go through that? So you why to go through that kind of like reasoning that it's like fallacious, instead of just forget that and just go straight where you need to go. Forget about trim out all the fluff. Essentially, that's what I would say. Go on, Ken. Sorry about that.
Ken, sorry.
No. Yeah, it's interesting. I'm on the research side now. So, but about 5 years ago, I was offered the opportunity to design a brand new chiropractic course. And so the principles that guided me were patient benefit and evidence-based practice. And so the course that I did end up designing and was validated through the university process, but has not been implemented, was very similar to the approach in this paper. Again, it was about the use of techniques that were beneficial to each specific patient. That was the approach to therapeutic interventions there. But so I can't speak to implementation or impact rather, because I haven't seen how that impacts firsthand. I know there's a similar approach being used at most of the other chiropractic institutions in the UK. I'd like to pull back a little bit though, and the question is about how do we implement this? And there is a challenge, particularly in chiropractic and osteopathy, but probably in all of the manual therapies. And that's that students sometimes arrive at a university course with, or rather because of, personal experience or family experience with that type of practitioner, a chiropractor or an osteopath, right? And so because there's a variety of approaches to clinical practice out in the field, different students arrive with different expectations of what they're going to learn and how they're going to then approach patients as they progress to become professionals themselves. So I think in order to facilitate implementation of a modern approach, you have to contextualize that by discussing the hard issues, by discussing the traditional paradigms and putting them into their historical reference frames as we move along, in combination with a reference to the development of medicine over time as well.
Yeah.
And for instance, you go to a medical doctor now and you don't get a talk on humeral theory, or you don't get trephining drilling into your skull, or you don't get a mercury cure anymore. Times have moved on. And so it's the same in manual therapies. The evidence has moved on. And so our practice and the teaching of that practice has to move on. And again, I'll just go back again, because that's what's going to be best for the patient, because that's what the evidence shows.
Yeah, absolutely. And with the different types of manual therapy, are we using different scenarios to teach that? So, or are we using the same thing? So, a hip joint mobilization is being taught in the same way as a spinal mobilization or manual therapy. Is it in the same way where we quite literally, we don't, as you said, alluded to earlier, we don't use the models that we used to use. Does that make sense?
Convex and concave, you mean?
Sorry, that just slipped my mind for a split second. Yeah.
Yeah, I mean, we sort of probably go too far the other way, a bit purposely casual about it, but then again, without losing the professionalness and the skillful of it. But we got some basic rules, criteria. Have your hands close to a joint line, stabilize one bit, move another bit. So those basic rules. But what we purposely try and do, and I guess this is a bit more undergraduate than postgraduate, because postgraduates have got these skills anyway, is demonstrate on one area and then just throw out case studies for all different areas. So we've never ever taught you the hip, but you've done this at the shoulder. So let's see how you get on. If you can apply those basic rules and stick within the framework, you're gonna rock.
Yeah.
And that's a powerful learning thing. If students can suddenly see, Oh, great. I haven't got to spend 5 hours on each joint of the body and understand the directions and the and be skilled at a joint. The skill is understanding the principles and the framework, and then that can be easily applied to anywhere.
Have you got any advice for current students that might listen to this, depending on when it's released, but advice for current students on implementing these practices the way that we're talking about manual therapy, if they've maybe coming from a course that's operating in a different way?
Yeah, I guess the advice is different to undergraduates and postgraduates, because undergraduates don't know any different. So in many ways, it's far easier. This is just what they sort of learn. Yeah. But like Ken said, some have got this background of their own personal experience as well that they map it against. So we can have those discussions, but in many ways, the undergraduate side of this is very, very quite straightforward. I guess on the postgraduate side, if somebody's got previous training and been on this course and that course and this, then there's some interesting discussions and to have around that.
Yeah,
I mean the construction challenge in the postgraduate field, let's say, is that some people come with predefined beliefs, shaped by experiences or prior training, and what we focus on is essentially to say that don't forget that actually manual therapy is a way to promote pain relief and a way to get somebody to be functional. So we try to move them away from this kind of mentality that, I'm going to do this, it's going to fix the problem, it's going to take away the pain in kind of like a switch on, switch off, kind of pattern. We focus on that, and we just tell them, you do that, you shouldn't spend ages doing this. This is not the purpose of the appointment. You should just do that, get the patient to understand, that this is, safe, relax, promote some kind of muscle relaxation and soft tissue relaxation so you can actually reduce the pain. If you can do that immediately, that's fine. If not, this is not going to happen anyway very, very quickly. But the idea is you do that to make the person understand that actually they can stand up, bend down, move their knee, their hip, whatever joint. So we don't really follow this kind of like very, very medicalized thing. Okay, if this is the hip needs to move like that, therefore you need to mobilize it like this. This isn't functional treatment.
And I think that most of the time, by the time people becomes sort of 5 or 10 years experience, you are probably going to do more of that. You're going to try something as they're moving. You're going to try something closer to what really annoys them, and therefore that's their pain. But as a new physio, or new clinician, I guess most people cling to the structure. They like the structure of having, well, I'm going to do this for this for this, because the learning process means they can compartmentalize each component. And as you said earlier, I think, I can't remember, it was Roger or Raz, but you said you kind of put it flipping on its head. You moving them and then doing all of the functional stuff whilst you're mobilizing, or much quicker than when you are, right, I'm going to mobilize this, let's review, mobilize, review. And so actually that is something that I think people, I'm sure it will be adopted, but it just takes time to get your head around that. Years and years of the structure is now going to be less needed. There's more than enough evidence for it. So, really, really interesting. Those are the few questions I thought would be really interesting to ask about modern, how it's applied to students. As you said, I think their fresh slates are probably going to be a lot. You're not even needing to sell them. They're going to need to work to do that to pass the course. But it's the rest of us that you work doing a really good job of updating the evidence and changing people's concepts of it. So, do we have any other university teaching specific things we want to talk about before we finish up? No. We did cover quite a lot on the last podcast, so this is just a nice extra, just in case there was anyone interested. So, look, I won't keep you any longer. Thank you so much for taking the time out on a Friday. I know you're really busy, but really, really much appreciated. Hopefully, when this comes out, people will be able to get an insight on how hard you've worked on it, and where you're coming from. Really, we're not just names on a page. You really are passionate about it, and hopefully, we'll see change in the right way. So, thank you very much.
Great. Thanks again, Warwick.
Thanks, sir. All the best. Have a good weekend.
Bye-bye.
Bye.